Have you heard of GP specialists? I mean, let's be honest, GPs are specialists, but this company does something that really does help primary care and in terms of managing patient care, other services, and basically, hopefully, managing your workload so much more effectively, as we're joined by Valid from GP Specialists as we tech enhance your primary care and learning. Hello, GP learners, and welcome to this episode where I'm really happy to be joined by Valid from GP Specialists as we're talking about GP Specialists. And this is going to be an awesome episode. How are you doing there, Valid?
I'm doing really well. How about yourself?
I'm doing great. So we've had a bit of a quick chat about some of the things that you've been doing. And I know I spoke to you before about some of this as well. And I'm blown away by the amount of stuff that you're not currently, only currently doing, but in the past have been doing as well. So why don't you tell us a little bit more about yourself and GP Specialists?
Sure. Well, first of all, thank you for having me on. I had a slightly unusual path into general practice. So I was a hospital medic to start with and was certain I wanted to do hospital medicine, and had an amazing FY rotation in general practice and decided to switch gear. So I did a lot of medical work alongside my GP training, developed a lot of acute skills while I was learning holistic care. And when I became a GP, sort of transitioned a lot of that hospital mindset, I think, into primary care. And as a general principle, I tried to create protocols, flowcharts, algorithms in most of the practices I worked at, and it tended to get received very, very well across the board. After a couple of years of finding my feet, working at consultant level in acute medicine, dabbling in sexual health, HIV, and secondary care, I found myself at a practice in Blackpool, where I was originally salaried, and put quite a few steps in place in this rather, deprived area with high comorbidity, a lot of deprivation, and streamlined a lot of processes such as lab result processing, prescription management, document management. And there was a heavy reliance on non-GPs delivering service because it's a very hard to recruit area. So we had, close to 18,000 patients, 2 full-time equivalent partners. We didn't have any salaries for a while. So the entire workforce was allied healthcare professionals. So they needed this guidance in terms of how do we manage scripts, how do we manage pathology? Because if the GPs did that, we would have never seen any patients, which obviously wouldn't have been ideal. Mm-hmm. So that went particularly well, and became a partner after 12 months and kind of ramped up what I was doing with the newfound confidence of partnership. And then it went from strength to strength, and a year later kind of became managing partner and continued to develop the services. And we were a CQC outstanding practice. We were doing lots of innovative things, and people at sort of PCN, ICB level started to catch wind of, our prevalence for CKD being higher than average, our management of certain things being exceptional. And we shared our CKD protocol with Lancashire South Cumbria ICB, and they implemented it in their health inequalities project to help the prevalence overall and increase the management optimization in terms of lipid lowering therapies, ACE inhibitors, SGLT2Is, managing things effectively according to urine leakage of protein, etc. So that kind of gave us a newfound confidence of what we could do. And before I knew it, I was sort of doing this for lots of other practices as a one-man team. And when it got to about 20 practices, I thought there's probably a business here. So I should probably be spending some proper time on this. So I ended up doing this full time, and it's just continued to go from strength to strength. We've now got a little over 50 GPs, more than about 40 pharmacists. We cater to hundreds of practices and over 20 PCNs, and that's in the space of about 18 months. So it's feels like a rocket of a journey, really.
Definitely. And I know through that you offer basically a suite of services and stuff to practices. I guess just to cover those, so I know that we were going to talk about a few of them, and there's probably going to be a more detailed episode where we talk about one of them in particular. But we've got document processing, we've got pathology management, and we've got pharmacy services. And then I know you're also currently working on an AI triage model. Is that correct? That's everything?
Yeah, absolutely. That's spot on.
Yeah. So we are going to cover the first 3 of those in this episode. The AI triage we're going to touch on briefly, but because of the depth I think that's going to need, we're going to cover that in a separate episode. So make sure you are joining us for that when that comes live, and we'll direct you to that towards the end. But let's get cracking and talk about some of the stuff that I know you've been really proud of showing, and it looks amazing as well. And I think we're going to start with the document processing, won't we?
Yeah, absolutely. So a lot of the services that we offer are a little unusual in some sense because it's not typically what we used to contract when we were a PCN or a practice. We used to focus on consultations, but as a partner, my issue was there was everybody we brought in from the PCN or anybody we recruited couldn't alleviate my work. So, the level of documents I had to work on as a partner or the kind of lab results I had to work on as a partner were always my problem. And I,
Mm-hmm.
and I could give out maybe a basic task to somebody else. I could maybe train them on something, but in essence, and I don't mean this to sound pessimistic, anything that carried any real risk sat with me. It was quite hard to give that away. So when I developed the service, the intention was, how can we take the partnership headache away? Or how can we help the higher level clinicians who are the ones that are also burning out and emigrating and having a really difficult time? How can we package a service tackling them? Because there seems to be loads of services tackling everything else, and this sort of difficult stuff everyone kind of seems to shy away from. That was my opinion, at least. So document management was something that I really struggled with when I was a partner, because it's not exactly heavily taught in your GP training program, and obviously there's a massive variation of what happens in document processing, and we don't really learn how to do coding properly. So on one hand, you're trying to learn about SNOMED codes, and then you're trying to do things around medicine reconciliation and write letters and all sorts. So we developed a service where we would do the A to Z of it. So it took me time to learn the process. So I didn't initially even know that a document had to be filed by somebody to be visible on your computer, and that it was like a uncharacterized document, and by looking at it you would have no information. So when a document says coding, when it says cardiology, this hospital, this day, is gone through a process of filing, and somebody has to actually do that.
Mm-hmm.
Then you have the steps of adding the codes to the document. After coding, you might need to reconcile medication. So we started individualizing all of these tasks and attributing which level of staff member do we need doing these tasks. So a relatively junior member of the team would be able to file a document. And in terms of PCN and translating that into a PCN role, we thought that a care coordinator would be an appropriate person to handle something like filing and triage of a document. Whereas the details of coding can be a little bit more nuanced, a little more tricky, typically require more experience. So we often use a GPA, so a general practice assistant, to do that level of work when we're using an ARRS, so when we're providing an ARRS service. Following that, the next step is typically medicine reconciliation, if it's appropriate. And this is a service that can often be provided by a pharmacy technician or a clinical pharmacist. And that kind of depends on whether you need the prescription to be issued alongside it, or whether you just want the medication to be added on, depending on if you're a dispensing practice or not. So these are the kind of nuances we've acquired over time when we're developing this service. The final option, and I had never seen this service offering, and this was the one that we actually started with, which was the clinical actions. So this was the specific section designed to tackle the GP headache. So interpreting scan reports, interpreting results of spirometry or ECGs or telemetry, echo reports, making onward referrals, issuing prescriptions based on specialist advice, shared care agreements, all this kind of stuff. That the more time-consuming activity. And we use advanced practitioners who are ACPs with digital badges to provide this level of service via PCNs. And if we have a direct contract with a client, then sometimes we use GPs to provide that service, because we have a lot of GPs that work for the team. So that hopefully gives an overview of document
Mm-hmm.
management. And we typically turn around stuff within 24 hours.
Wow, that's quick. If I can, just on that last one, in terms of the clinician actions, I guess there may be some out there who feel that continuity is a really important part of how you manage those documents and stuff. So how would you answer that question in terms of those practices maybe feeling anxious about, actually, I'd rather see my own document. There are always going to be people who feel they want that themselves and stuff. So how would the service fit in with that?
Yeah, so firstly, I think there's great merit to that. I think where possible, we should be pushing continuity. at all times. It's not always possible depending on your staffing scenario and your patient demand and everything else. So you have to be practical as well.
Hmm.
And what we try to do is we have a base level approach to how we handle a document, whether it's email system one, Docman, and then we will invite the practice during a calibration period where we will say, look, this is what we would normally do with a document. Is there any steps here that we need to be aware of? For example, if we pick up a cancer care, a new cancer diagnosis, does this go to a designated person? Is there a GP looking after cancer? Who do we send this document to who needs to be alerted? If there's a safeguarding concern, is there a designated person or team that deal with your safeguarding? So we create these internal protocols and they're
Hmm.
bespoke to every individual practice. And we've had scenarios where we've been commissioned at PCN level to do something like this. There are 5 practices. First of all, they usually all don't want the same service. So we'll tailor it at each practice level. But let's say we had 5 practices all wanting document processing. It's highly unlikely they have the exact same protocol at each site.
Hmm.
So we frequently have to tailor them practice by practice, and that's part of our onboarding process. So we would get that information in advance. And we have scenarios where people will say to us, I don't want to receive a letter to do something with. I want you guys to do that. We want you to take the responsibility of dealing with the letter, but I
Hmm.
want you to mark it with a comment. Just say FYI. If I've admitted the patient to hospital, I want you to do everything, but I just want you to send it for me to read, just for my own awareness. So we can
Hmm.
either send it to somebody for actioning, or we can just send it as an FYI to update them.
Okay. So what I'm hearing from that is definitely a bespoke service tailored around the needs of the practice, whether that's due to capacity or whether that's due to preference and stuff, and working with the team to make sure that works as best as possible.
100%. And we know that's not common, but our kind of selling point up until now has been very much we're led by GPs and we're tailoring services to you, and that's probably what you're going to get over and over again. That's kind of our whole style.
Okay, cool. So we talked about document management as one of the 4 kind of key services you offer. I think pathology management was next, wasn't it? And so tell us a bit more about how that works.
Yeah, so pathology management was the very first service actually that we started, and the reason we the reason we started doing pathology management is this is the only service I was unable to get any support with. I've had several companies offer to process my normal results, which was convenient, and everybody seemed to have a solution for the ones that don't take any time to action. But when it came to reviewing medical records and looking at results in context, nobody offered that, and it seemed to be outside of the skill capacity of most of the staff we would take from the PCN2. So we'd have plenty of FCPs seeing patients, but none of them seemed to know what to do when the connective tissue disease screen was positive. So it was really, really a big sense of frustration for me. So I spent about 3 to 4 years mapping out what to do with all possible eventualities in pathology results and kind of tailoring them to primary care, but looking at it through a secondary care lens. So what I mean by that is understanding how the system works in terms of EPS, messaging, SNOMED coding, what matters for QoF, what matters for prevalence, but then looking at secondary care guidance and legal precedent to decide, well, do we really need to do things the way we do them, or is there a more appropriate, efficient way to do them where we're generating less appointments? Are we creating our own problem essentially?
Mm-hmm.
So we trained our staff on obviously how to do this. Lots of them have been trained by me and work with me. And what we did was we actually show our rationalization of how we approach pathology to our client before we start. So we'll say, here are some categories of results. Here's how we think about processing them. So are you okay with our thought process, or do you find it's risky? Does this make you uncomfortable when you're hearing what I'm telling you? Or do you think we're not taking enough risk? And it's very unusual that someone says to us, I don't think you're taking enough risk here. I think you're being overly cautious. It's usually the case that people say, your LFT threshold is a touch high, and I'd like it to be a bit lower. We're very happy to accommodate requests for lower thresholds of actioning. And we have national guidance as our evidence point. So we demonstrate that, we show it, it's all very transparent in why we do what we do. And then because that's very theoretical, we then have a black and white cutoff list as well, where we'll say, well, there's your rationale for how we tend to approach results. And here's the black and white of what we're going to do with the potassium when it reaches this threshold.
Hmm.
And, we're going to panic about sodium when it hits this number based on the guidance. And we also invite the practice to tweak and tailor that policy as well. So once we've agreed on how to interpret the results, we then agree on the process of actioning. So we'll ask them, what is your demographic of patients like? Will they accept a text message explaining the result? Or will they need that to be a consultation? And depending on that, do we send tasks? Do we use booking links? Do we just SMS them with a patient information leaflet? So the entire process of communication is mapped out with the practice in advance. But we try our best to give a complete service. So any associated coding for prevalence and QoF data is done by us. Any prescription that needs to be generated is generated by us and sent electronically to the chemist for the patient,
Okay.
unless they're dispensing and they have a particular arrangement that we need to follow. And if there is an emergency where there's a potential threat to life with a very low, potassium or magnesium or HB, then we will ring that patient and we will say, there's a genuine concern, you need to go to A&E. So that's kind of the level of care that we deliver, and that's the level of bespoking we go through to be able to deliver that care. And it's probably our most popular service.
Definitely sounds powerful. You mentioned about contacting patients for those critically abnormal results and stuff. Have you had practice who felt that would be better if we kind of did that rather than yourselves? And how has those interactions gone with patients when they've been contacted by service and not by their practice?
So patients, so there's two bits to this. So the first thing is we don't ring them for normal results. So we're not going to be, wasting their time. We send messages if things are normal or there's low risk. If there is an abnormal result, but it doesn't pose a threat to life, we will not ring that patient. We think conversations like that are best had by their own surgery.
Yeah.
So if somebody has a positive fit test, for example, and it's not been consulted, it's not been mentioned in the consultation, there was no reference to a 2-week wait being needed, it's inappropriate for us to ring that patient who they don't know to have that sensitive conversation. So we will send an urgent task internally because there are risks with messages not being received and delayed and everything else. So urgent results that are non-life threatening, we do urgent tasks. Routine stuff, we send messages. The life threatening stuff, we feel we would struggle to defend not ringing the patient.
Mm-hmm.
And the reason is we have looked at the result, we're making a decision. If it's in hours and the practice is passionate about ringing their own patient and they have an on-call list and they want us to put it on there, that's fine. But the thing is, we have a 24-hour turnaround for lab results. So we sometimes end up looking at a lab result at 8 p.m. Because if a lab result comes in at 7 p.m., for example, we will still want to clear that because we promise the practice to do it within 24 hours. So rather than catching a potassium of 7 at 8 o'clock the following morning, I think it's better if we've seen it at 9 p.m. to then ring the patient, because all you would have done is delay the time to contact that patient. Yeah. So we feel it's more defensible for life-threatening results for us to ring them if it's out of hours, and if it's in hours and the practice wants to do it, we're happy to pass that to the practice and follow their protocol. But we take the default stance that we should be expected to ring them because that's kind of what you're paying us for.
Sure. So kind of like an out of hours service follow through that you would hope works, and sounds like it does.
Yeah, absolutely.
Cool. Okay. So we talked about pathology management. You talked about obviously how you process both normal if needed, but also the mixed and the abnormal results and stuff that come through for practice and things. I think you also mentioned the pharmacy services that you offer.
Yeah. So our pharmacy service has almost grown out of accident, to be honest. So we had people that could sign prescriptions because, as you can tell from the first couple of services, this was a very administrative support project in the beginning. So 6 months ago or a year ago even, only the left-hand side of this service existed, which was around signing prescriptions, whether they were repeat prescriptions, medications with queries. And what we found is, just because of the kind of caliber of people we had following the training we did and the fact that they were all prescribers, they were just also able to do very high level consultations. So our clients would request that we do consultations. And we actually, so we never marketed this, we never advertised it. But when they would get the task back stating, this is a prescription request, these are the things that are missing, I think practices get a sense for, this person's really diligent and they're really investigating the record, and surely they would do a good job if they were consulting our patients. So when they would lose a pharmacist or somebody would, not be available, they would ask us to cover. And what kind of happened is the consulting became a massively popular service because people were just so happy with what we were delivering.
Mm-hmm.
And obviously, because they're trained by me and other GPs, we emphasize using ARRS templates. We emphasize QOF data. We emphasize capturing prevalence information. We talk about if you're not sure what to do. This is actually probably quite an important point that I've just completely not mentioned because it's quite basic for us. But none of the work that we do goes back to the practice. So if the clinician or the worker has a concern, we have a GP all day, every day that they're supposed to ring. So if a pharmacist is in clinic and they're dealing with a diabetic and it's complex and they're not quite sure what to do,
Mm-hmm.
they can either advise to call the patient back, put them on hold, they call our on-call GP, the GP gives them advice, that GP's name goes in the record, and we try to fix our own problem. We don't want the practice to think that we're pushing complexity back on them, because that's exactly what used to frustrate me as a partner. I used to think, you've done all the easy hypertension reviews. Now you've got a bit of complexity in a menopause case and you're knocking on my door and I've got my own clinic to do.
Mm-hmm.
So we're trying to take that away from the partnership and the GPs in general. We're trying to make their lives a bit easier. So in a nutshell, the admin service is great. That's the bread and butter. The consulting service is relatively newer. And I guess what's quite novel here is we made this review service. So we actually voluntarily suggest innovation to practices. So we will say to them, we've been doing your medication reviews. You're giving us 10, 15-minute appointments. We don't think we need them. So we said to practices, we said, look, you're booking our clinics in, and I'm not going to lie to you, they're easy clinics. Because, you're giving us med reviews, 10, 15-minute slots. They're on like 5 medications. There's no need for the clinic to be this long. So we think we could risk stratify your patients and make sure their monitoring is in place, make sure they're not frail, make sure they're not high risk. And we think we could do your reviews for a certain cohort of patients in a fraction of the time as an administrative task. And we did that. And we found on average, practices were saving like a third in their pharmacy time, and they were saving usually thousands of pounds. So the medication review from notes has been an incredibly popular service, because what people don't realize is 10% of your patients take up 80% of your time.
Yep.
So a lot of your patients are on little to no meds. But if you're on one med, you need some sort of med review. And why should that be a 10, 15-minute telephone call? If this person isn't going to A&E, they're not, losing their medication, they're not having a problem, that could be almost like an administrative exercise where you make sure the monitoring is available and you send them a message saying, I'm really happy with the way you're taking your stuff, carry on. Any concerns, let us know. So you can actually get through, in my opinion, 60, 70% of your patients as an administrative exercise in a pre-selected, stratified method. And we demonstrate that data to practices and we say, here's what we can do for you. It'll save you quite a bit of time and effectively it'll be cost positive. And then the final thing to mention here is we had a PCN almost insist that we deliver extended access for them after they saw the style of our chronic disease reviews and the level of detail that we went into and the way we hit QOF and KPIs. And the fact that our pharmacists, by definition, would just be de-prescribing and exceptional clinicians. So they insisted, and in their area where it's very rural, they had massive uptake. You had all these people that couldn't attend in hours. It's a long drive to the practice, so they couldn't just pop out in work. They have to kind of take the day off if they were going to come into the practice. So extended access was massively valuable. And I'm sure this isn't, the be all and end all or why it happened, but they got nominated for PCN of the year this year as a finalist, and they're very happy, and we're very happy, and their patients are very happy. So it's been a massively positive experience.
If I can ask a couple of questions on this particular part of the service. So one of the things you mentioned a couple of times was using things like templates from ARRS and stuff. So is that something that you provide, or what happens if a practice doesn't have those templates because they may not do?
Yeah, so we have our own protocols.
Mhm.
So we mention Ardens because clients like Ardens. But we have our own standards. So, for example, when we talk about medication review from notes, it's our searches that we run,
Mhm.
and it's that data that we present. We have our own criteria of what is acceptable in a condition. So, Ardens for most people almost acts as a safety check. It acts as a, make sure you don't forget to add this code into the record. But in
Mhm.
terms of our diabetic protocol, um, let me give you an example of how detailed our protocol is. So we were having discussions with Invocana, the drug company, and trying to figure out in what scenarios of HbA1c control would one SGLT2i be more effective than another based on the evidence that's available in RCTs. So as a company, we debate over subtypes of drug just to have better A1C control.
Wow. Okay.
So so our protocols are more detailed than the national guidance. And the reason for that is if we deliver an exceptional service, people will continue to use us, because then what I don't want is having someone that does a chronic disease clinic for me and I don't know what capacity or what capability they're working at. And I almost feel like I need to double check their work.
Mhm.
Whereas if I know, these guys are doing cutting edge research into these fields and they're rationalizing on like a granular level what treatments to use and what the side effects are, and they've got excellent patient information leaflets, you can hand that service over with some confidence.
Okay. And in terms of that oversight and that governance, you mentioned that you have, effectively an on-call GP to support the staff who are making these decisions and stuff. Um, have you ever had where that GP will contact the practice or have the need to do so? And if so, how does that work? Or is it
Yeah,
through
so
the clinicians themselves?
so it doesn't tend to ever need to happen, and the reason is we accounted for all of this early on. So
Mhm.
when a pharmacist is working for a practice, by default, the entire set of on-call GPs need access to the practice,
Mhm.
and I, as the CEO, need access to the practice. So if that pharmacist has an issue and someone from the practice can't do something, switch on their Accurix or whatever it is, we will do that. So we will activate the Accurix. We'll make sure things are working. We'll review the notes. We'll put an entry in ourselves, and it'll be specific for that scenario. We often find that when people see how responsive we are and how integrated our pharmacists are into their team, we offer them channels. So we'll say, as a practice, you probably have Microsoft Teams. Why don't you create a channel with our staff and your partners and maybe your ops manager or someone, and use it
Mhm.
as a communication method. So if you've got a concern about something, you want to raise a case where you want some clarification, we're all in there. We all have visibility. Bang the EMIS number in, the date, whatever the issue is, and we can discuss it. We can reflect on it, get back to you. So most of our clients interact with us quite regularly, and we don't. So I'll give you an example. I have the mobile number of most of the practice managers and lead partner for most of the clients that we work with. And if I don't, it's because my clinical lead has set up the contract and he's got their details.
Mhm.
So we have quite a personal relationship with our clients, and they can kind of ring us whenever they want, if they've got an issue or concern.
Okay. And you also mentioned about the variety of different platforms practices may end up using, particularly in terms of contacting patients. So, do you have those modules yourself, or do you use things like remote access to then access the practice base? Do you get what I mean in terms of
Yeah.
communication?
So the only things we've ever needed to use are AQRX, GP Buddy, and Surgery Connect. We've not needed to use anything else. But if we did, we would either procure it or have help from the practice in securing it.
Hmm.
So we have our own access to like EMIS, TPP, Docman, etc. So we've not come across a scenario where we needed to do something and couldn't from a technical standpoint, because we meet all the cybersecurity sort of essential criteria. So we have a HSCN connection, we issue our own tokens. We don't really need software support from anyone, and it's
Hmm.
just a case of do we have a number of clients needing a particular thing, and if so, then we will just make sure we have that thing so we can service that client.
So we've talked about documentation, we talked about pathology results, and we talked about pharmacy services. Can we talk about AI triage? Because I know this is something that a lot of people ask me about, and I know we're going to go into it more detail on our next episode, but just tell us a little bit about this whole AI triage that you're developing.
Sure. So I'll tell you what I can, and I'll give you an overview. We have a chief technology officer who this is like his baby, right? So he's really, really protective over it, and he knows all the ins and outs. Well, he should. He spent about 3 years training it. So what I would start with is a bit about the journey. So the CTO that we have is a intensive care doctor down in London. I think he's ST5 or ST6. He's just sat his CCT exam, and he's got a massive interest in data, and data analysis. And he's done I think he did a degree in big data at Harvard, just out of pure interest. So but he's from a family of GPs, and there's this whole concept of patient demand, and not knowing what to do, and the receptionists sometimes are confident in triaging cases, and you send them on navigation courses, and sometimes it feels like they don't work, maybe they do work, and there's this whole concept of care navigation and managing risk of assessment and things like that has been an issue for some time. And I say that because we've made care navigation protocols obviously at PCN level for PCNs. So he felt that it shouldn't be overly difficult to get an AI to learn how to do triage. So Microsoft have an AI, I believe it's called the Microsoft Azure base. And from my understanding, it was the AI that was used to develop the COVID triage pathways in the US. And they were obviously allowing the base model to be used by industry in the UK for primary care. And there was a company in Birmingham called CloudSurge who essentially got that contract. And so my CTO spent the last 3 years developing that AI model using their software team, training it, giving it loads of cases. And what they've ended up with is an AI that can basically integrates into EMIS System 1. It supports over 1,600 symptoms, 840 conditions, and so I have to be very clear here because I don't want to oversell the AI, which I feel like a lot of people kind of oversell their product. So what our thing is good at is acute symptom triage. So
Okay.
this isn't a switch off everything else and just use this type of scenario. This is think of it like an acute patient management aid. So the people that have an acute concern, that want an acute appointment, this is for them more than anyone. And there's other functionality built into it because you just want it to be as helpful and as standalone as possible. But it has a central benefit, and that's the benefit I want to emphasize. So so obviously it makes autonomous evidence-based decisions. So it's not a programmable algorithm where I can change one line of something and then it starts doing something else differently. It's truly AI, as in it learns over time, and it does what it thinks it should do in terms of question answering. It's available in 17 languages, so that's obviously very helpful from a health inequality, patient engagement perspective. It operates as a chatbot, so it will sit on the practice website, and it looks exactly like this. So it'll say, "How can I help?" And then you'll interact with it. It'll ask you follow-up questions. Firstly, it'll verify your identity because it has spine connectivity. So it'll confirm who you are, confirm your date of birth, etc., confirm you're registered with the practice. And then it will clarify your symptoms, ask you to rank them in severity and go through them. I can show a bit of this. And if I show you an example, yeah. So this bit here where it says appointment booking. So this would be where your acute concerned person would click. So we would call this I don't know, worsening symptom or acute problem. We'd come up with we'd speak to the practice about what they want that language to be. What would their patients respond to, and that would be the area that AI would work in. These other areas like general inquiry, admin related queries, these are algorithms. So there's no AI here. So these are completely customizable. We can do whatever we want with these. So if you want to split your admin queries into 20 sections for expediting referrals, etc., and that going into a particular area, all of that is doable. And when it comes to long-term conditions, we do the same thing. We create a long-term condition area, and we ask the practice, who does your diabetes, who does your hypertension, how long are their appointments available in advance, and we can map all of that in an algorithmic way. So that'll be bespoke to the practice's needs. It's very tailor-made. So an example of what it looks like is here. So what will happen is, the patient will say, I have chest pain. It'll then start asking, do you have any of the following symptoms? It'll go through the red flags, and it'll show the delineating features that it will use to decide on urgency of what to do. So then obviously the patient will self-select which things apply to it, which ones don't. So some of it will be self-selection here, others will be clickable. So where they're clickable, it would likely initiate a new line of thinking because it might be very significant information. Goes through how long have you had trouble breathing. We don't set how many questions it should ask. It essentially asks questions until it's happy. Is the oversimplified way of explaining it, because I'm not the CTO. So obviously the CTO will have a more technical answer to these questions. And essentially it'll then give you a summary, and if it's safe to, it will suggest an appointment with a set of urgencies. So it'll say, this is classifies for an urgent appointment, or it classifies for a routine or semi-urgent appointment, or it will say, actually, this is inappropriate. This needs to go to A&E, and you need to stop and ring 999. So as an example, when the patient's done with the case, the practice will have a dashboard, a little like on Ask My GP or Accurix or something like that. So you'll get a list of patients, you can see the urgency. It will map out your monthly demand, and it can further subdivide it into daily demand. So you'll get an idea for when do your patients contact you, what time. This can be on all the time, or it can obviously be switched off at certain times. You can control the accessibility of the AI.
Okay.
And then it'll give you like a summary of a case. So it'll present the information, it'll give you the history, and it will have and I don't know how to describe this technically, but essentially it has an idea of what some of the things could be potentially. Obviously, it doesn't do anything with that in terms of it can't treat the patient or tell the patient what it has, but it's almost like a clinician aid. So when the clinician is then assessing that patient, there might be certain things that they don't consider, because they might look at a history, it might seem vastly reassuring. There might be one symptom that's a bit concerning, and it'll list almost the things that you should try to rule out in this scenario as a helpful feature. And these are the bits that I kind of get asked about the most, and probably the bits that everyone's really interested in. The fact that it has DTAC, which actually, if you don't mind, I'd really like to stress. And the reason I'd like to stress it is I'm aware of certain sort of services or providers being out there that access patient data and interpret them in some way and don't have DTAC. And from a liability perspective, I think that's really important that people are aware that, if someone's accessing your data, that needs to be a requirement. It's a registered medical device. So this sort of stuff is where you're going to have to speak to my CTO. Apparently this is really important, and it's a basic necessity. And I hadn't heard about any of this. So obviously he deals with all of this. And I couldn't tell you what a CREST penetration test is, but essentially it's very important, I'm told. And it's necessary. So this probably means more to you than it does to me. So
so I covered a lot of that in the kind of certifying AI episode that I did a short while back, which people can go and have a look at. Like I said, we're going to go into that in more detail when we go through the tool in depth next time round. I guess just to get some more details of certain things that people always want to know when it comes to these different things. So the first one I'm going to ask you, Valid, is onboarding. So you've shown us a suite of services that you offer and stuff. So how do practice on board with you? What average time frame? And I know there's no such thing as a definitive one because everybody's different, but on average, how long will it take for a practice to onboard if they were looking at using these services and stuff?
So it varies. We used to have an onboarding time of 2 weeks, but I have to be honest, we've had a relatively large surge in interest, and at the moment it's probably closer to 4 to 6 weeks. And the reason for that isn't necessarily the inability to provide a service. It's because the way we deliver our service, we first need to flesh out what the client actually wants. And then we have to produce that in protocol format. So this is the way we work. So we don't sign any contract until we've demonstrated in a protocol exactly what we're going to be doing for you and you're happy with it. So Usually when they look at a protocol, there'll be some feedback, they might want some tweaking. So there's that back and forth, and that process in itself takes a couple of weeks.
Okay.
And then obviously once that's done, there's an agreement, then there's a contract to sign, then there's people to allocate, they need their logins, we need to make sure that ARRS is working. So it's the mobilization that takes 4 to 6 weeks. If everything was spot on, let's say they looked at a protocol, they were happy, they signed off on it on that day, and they signed the contract the following day, it would literally be 2-3 weeks.
But that never happens in life. So
Yeah,
let's be honest.
it never happens. Someone's
Yeah.
always on leave. So 4 to 6 weeks is safe.
Yeah. Okay, cool. And I guess the question everybody always loves me to ask is about the cost. So can you give us an idea of what practices would be looking at if they were looking at these different services and things?
Sure. So some of them are really straightforward to price, and some of them are a bit more nuanced. So for example, with blood result processing, we broadly categorize them into 2 services. So we have service option A, which is mixed results. So meaning you're going to give us unfiltered results. They're normal and abnormal. And we work on the premise that roughly half of the results are probably going to be normal. So we charge 79 pence per result in that scenario. And by result, I mean, probably the most accurate way to describe it is a line of results. So, if you're on EMIS and you clicked on it and it opened, there might be 3-4 batteries in there, but that's one result.
Mm-hmm.
So if you click on one result and it's UNE, LFT, bone, that's one. And then if you have to click on another one underneath it to open another window, that's number 2. So
Yeah.
79p a result. If it's abnormal only, so you're using some sort of RPA, or you've got somebody from your team filing your normal results, then every result we have is statistically more likely to need something to be done. So we charge twice as much, so £1.58 per result. And this is inclusive of coding, prescribing, SMS, everything else.
Okay.
When it comes to prescribing, it's actually the exact same pricing. So for a repeat prescription, which is considered generally simple and easy compared to a prescription with a query, for a repeat, we would charge 79 pence per script. And that's a script, even if it has sort of say, 10, 15 items on the script that need to be checked through, that's fine. But it's one physical click for the signing. So think of it as per click, if that helps.
Mm-hmm.
And then for a query where you need to investigate the record, look at past meds, look at monitoring, do everything else, £1.58. So same pricing model as the bloods. The documents is harder. And the reason it's harder is there's multiple layers of what could be done in a document processing offer. And the process and the intricacy requires a lot of discussion, because in one practice you have an administrator triaging, in another practice it's GPs that do all the letter triaging. So for our definition, triage is an admin task. For them, it's a GP task. So, and then we can offer it as singular unit cost. But then most practices don't just need one thing doing. They don't just need their letters triaging. They'll need them triaging, filing, and coding. So we'll have to group that service together, and then we'll create a package, and that package is normally discounted. So it's usually cheaper than procuring the service individually for 2 or 3 things. So
Mm-hmm.
that is going to be a bit hard to give you a price on that one. So that's too tailored for me to give you sort of random numbers.
So given how that works, I suspect, and I think I saw it on the sheet you gave us as well, that you can use things like ARRS funding to try and support some of this and things. So just to confirm, number one, you can use ARRS funding in certain ways. And number two, do you see the potential for using the GP in ARRS funding for some of this to help practices in the future? Bearing in mind the contract literally just dropped yesterday. And a quick reminder, these prices are at the time of recording this episode as well.
Absolutely. So first of all, excellent question. So we were internally just talking about the GP via ARRS. So I've got a bit of an idea of how that might work. In terms of ARRS funding, so yes, so every single service that we offer, we can fund through the ARRS. And that's because they all can fall into certain categories. So, looking at a document at a very basic level of reading, filing, and triage would be well within the capabilities of a care coordinator. More detailed nuance coding, more detailed senior administrative work, we would class as a GPA. If you needed meds reconciliation, depending on whether you needed a prescription to be issued or not, we would put it under a technician or a clinical pharmacist. And then for the clinical interpretation, if we have a very experienced clinical pharmacist, they might be able to do it but usually it would be an advanced practitioner, so like an ACP with a digital badge. They would be the ideal category of people to provide that service. And obviously, up until now, we've only ever used GPs if it was a direct engagement contract. And that what usually would happen is somebody will want bloods to be processed. They don't have any ARRS funding available. They're contracting us directly. We would provide them with a GP. It's at no extra cost, so the price is exactly the same. But
Mm-hmm.
we would be offering it on a volume basis. And what we find is, because I'm not completely sure about the funding, but I think there's a formula for how much GP funding you can use on the ARRS, and I think they have to be within a certain time frame of graduation.
Yep.
So that's actually not going to be a problem, because essentially I give a lot of talks to the postgrads about career options and making the most of your career, you know, in this modern age when there's a difficulty in the workspace. So I've probably got about 50 to 70 GPs waiting for some work. And essentially when a contract comes up, we will start to offer them work and everything else. So we will have lots of GPs that fit that criteria, who we can set up from an IT infrastructure perspective with the remote access, the HSCN connection, everything else in the laptop. And if we can then get that funded through the ARRS scheme, they could help out either with consultations, or they could help out with blood processing, or anything that's really required, as long as it's obviously within the reimbursable rate. So I think it's definitely doable, and we have a plan to do it.
Awesome. So that's hot off the press, everybody, because that came out just yesterday. There you go. So thank you, Walid. I've really enjoyed this episode and hearing about the variety of services that you offer. I think there are absolutely practices out there where those kind of services are going to be really effective for either practices who are facing current challenges, but also practices that just want to do more. You know, sometimes there are things where you just wish that if you have the right type of capacity support, then it can enable you to be more productive and more effective for the patients that you serve. And I can absolutely see the power of how many of those services can help practices moving forward and stuff. So if a practice did want to look at this, where would you recommend they go?
I mean, the ideal scenario would be that they'd probably look at the website first. So we've got some testimonials on there. We've got what I would call the ideal mapping of an exercise. So we talk about like the journey of a document being processed. And what I almost encourage them to do is get some under the hood information first. You know, do you know currently who is filing your documents? Do you know who is coding your documents? Do you know how many they're doing in an hour? Do you know your effective unit cost per document? So that when I give you a price, at least you know this is good, it's fair, you know, at least you have something to base it on. Because I give people quotes and I'll say, well, this is what we charge per prescription. And they have a pharmacist doing prescriptions and they don't have any idea what it's costing them. So what I often say is we will likely be more efficient on cost than anything you're doing in-house, because it's deliberately designed to be that way. However, you will always then be able to repurpose the person you have to do something else. It might be income generation or quaff work or something else. But once you've looked at the website, we have a contact us form where they can submit their interest as a potential client, and they can pick the exact service they're interested in. And this document I've shown today is a very generic overview. We have bespoke, detailed documents for every individual service. So if somebody said, you know, I kind of liked what you showed about labs, but it wasn't very detailed, we've got whole rationalization guides for how we do labs. We've got entire pricing structures, each individual step mapped out. We even have examples of ARRS templates that we send. So this is a very, very basic overview, because there's a lot to cover, but there's significantly more detail available. And obviously you can just book meetings with us through our website, submit interest, and we'll organize meetings.
Cool. So if people do want to do that, then absolutely go to the website, which is gpspecialist.co.uk. I will put the clickable links to that down in the show notes. So just click down below the video onto more, and then I'll bring that up for you and you should be able to see it from there. Thank you, Walid. As I said, I've really enjoyed this episode. I've actually got some ideas I want to run by you as soon as we finish to figure out if these are things that we can look at and stuff. If you do want to check out the AI triage episode once we've recorded it, that'll be coming up right about here. Alternatively, there's probably other content there for now until that's done. And as always, we'll be here to tech enhance your primary care and learning. We'll catch you in the next episode.